Okay, good evening, everyone. We're just about to get started. As we stated also, before we leave, we're going to have a training in addition to the conversation and the people we're going to see. We will offer naloxone to individuals that are here for the training. If you know you're going to want to leave with a Narcan kit, there is some information that we need from you. So Marcia is going to be in the back. Just make sure you get one of these so you can fill it out. It's for data purposes. We have to track the medication. My name is Mark Jenkins. I'm the Executive Director of the Greater Hartford Harm Reduction Coalition. I'm going to right now turn it over to Eli Mercado, who's going to get us started.
Hi.
My name's J.C. McCauley.
I'm Naisha McCauley, and you're watching AccessTV.org.
Greetings, everyone. How you doing today? Awesome. Like you said, my name is Eli Mercado, leader here in the city of Hartford. I want to welcome you all to today's great discussion, and thank you all for being here. I'm sure you guys got a lot of other places where you could be. So I'm the executive director for Know Thy Neighbor, for Conocer Tu Vecino. And we started this years ago with our current police commissioner, James Avella. Him and I got this going here in the city. And we're in two different neighborhoods. We're in the Clay Arsenal and also here in the Frog Hollow neighborhood. The great thing about this is that this group here in the Frog Hollow neighborhood meets every other week. And they talk about issues, concerns, and then we work on solutions both in the short term, but then also in the long term as well. And in these meetings, we have, the community, we have the Hartford Police Department. Big shout out to Officer Rowe, who's a big part of our meetings, and the other officers that are here as well. We're also partnered with the Hartford Fire Department. I see Captain Okendo over there and the lieutenants as well. We're partnered with AMR, other organizations. And this last time around, the community started talking, and we started talking about what can we work on. Every quarter we work on an outreach project. And one of the things that the community discussed and in this group was the opioid crisis here in this area. And as we know, they're going to talk about some of the data. It is pretty bad in this area. So Logan, in fact, is our team leader here in the Frog Hollow area. And we said, okay, let's bring in some of the professionals, individuals that know this work better than us, but we wanted to help and bring this discussion. And that's what brings us here today. So we reached out to Mark and his organization, and they do amazing work. But we wanted to have this discussion here in the Frog Hollow community. And then we have Logan. Logan, would you like to say a few words? Logan is our team leader here in the Frog Hollow neighborhood for Know Thy Neighbor.
So as Eli said, Know Thy Neighbor is all about people just coming together to identify both what's good in the neighborhood as well as the things that we want to make better together. When we first identified opioids as the issue we wanted to take on, to be honest, I was kind of nervous because that's kind of like, what the heck are we going to do as just 10, 15 volunteers? But everyone in this room shows that there's something that everyone can do. And so we hope that this is a part of a conversation where we all can ask the question, what can we do? Because as it's going to be brought up, like we are in ground zero right now, and that there are lives hanging in the balance and that we need to do something. And so if you want to be part of that group, we have little flyer things we can give to you. We have phone numbers, we have emails. Reach out to us and you can be a part of it. But we're just thankful that you're all here because just like those 10 to 15 people, this started with an idea. I'm excited to hear the ideas everyone here has and where that might lead.
Awesome. Thank you, Logan. And again, thank each and every one of you. And we're going to get started with today's discussion. And then we'll have a training as well where you guys could leave here equipped in the unfortunate event that you come across a situation. At this time, I'd like to call Mark to come back up.
All right, thank you, Eli. Again, welcome. Thank everyone for coming out. We're going to start off. We're going to have Dr. Steve Wolf from St. Francis. He is the director, medical director of the St. Francis Emergency Department. Share some insight on where we are in this process. And we have a couple of other people who are going to be sharing some information. I'd like to take a quick moment and thank Liani Arroyo from the City of Hartford Health Department for coming out. I see Pastor Robert from Temple of Faith. And if I'm forgetting some others, please forgive me. You know, I'm sure I'll see you and say, and bring your name up a little bit later. Dr. Wolf.
You didn't tell me I was going to be first. Good evening. Excited to be here, and I see a lot of familiar faces that who are working to kind of end this scourge or help the people of Hartford. So at St. Francis, over the past several years, we of course have seen a huge increase in overdoses, significant deaths, unfortunately. But there is a little bit of ray of hope. We're seeing less this year compared to last year, which sort of mimics the state medical examiner's numbers. We don't have the final numbers for last year, but I'm hopeful that because of the work that everybody's doing and the increased awareness, that maybe we've rounded the corner a little bit. So some cautious optimism, but nothing to celebrate yet because still over 1,000 people are dying in this state alone. There are a couple of things that I wanted to touch on. And we're over in the north end at St. Francis, and we've had for many years a very robust system of substance use disorder treatment. So what we're doing now is really a good overlay of what we've always done. We've always had our crisis workers who are great in the ER, seeing everybody with behavioral health and substance use disorder. So we don't separate that out. And so we've always had that, and we evaluate patients, and we do a lot of inpatient treatment for whether it's opiates or alcohol or anything else. So that's been always there. But thanks to Department of Mental Health and Addiction Services, a couple of years ago when they started with a grant for Suboxone, and we started with that in December of 2017. And we now do Suboxone initiation in the ER as well. So not necessarily everybody wants to be treated in inpatient setting, nor can they, or they have a job and they don't want to take time off. So Suboxone is a nice way to start somebody on treatment, but yet for them to maintain their activities. So we've done that now for about 1.5 years. They're also Suboxone initiation at Inner Community, which is on the Mount Sinai campus. And then we also have a relationship with several providers on the outside, Clean Slate, Village, oh gosh, I'm blanking on a couple of others. And Wheeler, just to do warm handoffs on people. So we will keep the patient in the ER, start them on Suboxone. Yep.
There's someone with a gray Camry with mask plates. Gray Camry with mask plates blocking the driveway across the street. Okay. What was it? Gray Camry with mask plates.
So we'll start the patient on Suboxone, stabilize them, and then do a warm handoff to one of those other agencies. They get the full evaluation, they get what we've treated them with, the lab work. So it's a facilitated handoff. If you go to one of the outside providers off the street, they may not be able to see you right away. So this is sort of a safer way of doing it, and it avoids perhaps somebody overdosing while they're waiting for a appointment. But those outside providers are available too, so it doesn't mean that you have to go to the ER to get treatment. So we're hoping that we're also giving Narcan to high-risk individuals. Demas gave us a grant for that. So we're handing out Narcan for those people who may not want to stay for treatment, so at least we'll try to keep them safe. And I'm working with Mark to do a harm reduction kit so that we'll give people who don't necessarily want to stay again clean needles, sterile equipment, so that hopefully we'll keep them safe until they decide that they do want some treatment. So I'm hoping, and I think that with all of what's going on between the Narcan, first responders having Narcan, families now have Narcan, the greater treatment that's available to people now, and the fact that we're even having these forums, that we're willing to talk about addiction, whereas before it was sort of a family secret and everybody wanted to try to keep it quiet. I'm thinking that pretty much all of these efforts make a huge difference in the outcome. So I'm hoping that while the trend has leveled off some with overdoses, that perhaps we can now see the decrease. The one last thing, the medical profession has learned a lot over these past several years. I think it's clear from everything that you've read that certainly the pharmaceutical industry has had a hand in this epidemic for profit reasons. There was certainly a lot that was unknown about addiction in the medical profession. It wasn't well understood, it wasn't well taught, either in school or in residency. That's changed some, I don't think enough yet. I think the medical profession still has biases about enabling that are impacting the treatment that is being offered to people. The harm reduction issue is still something that the profession has to work out. They still feel that a lot of that is enabling. So we have our own biases that we have to work out, and that's going to take a little while. But with education improving in medical schools, frank discussions now happening all over, I'm also confident that that will change. And we've certainly changed our prescribing habits. The idea is to try not to keep to a minimum new patients starting on addiction because of prescriptions. So I think with everything that's being discussed, we've got a reasonable chance that we can turn the corner over the next couple of years and start to really reduce the death rate. So, Mark? You want Peter to go next? I'll let you do the introductions.
Okay, thank you, Dr. Wolf. Let's give Dr. Wolf a round of applause. I'd like to bring up another doctor who's been working closely with this and with our population. She's on this side of town, actually. Dr. right here in front of me, I'm looking around. Dr. Robin Deutsch, ladies and gentlemen.
Hello, good evening. I hope you don't mind. I'm going to keep my coat on, as most of you have. Thank you, Mark, for having me. I work at Hartford Hospital. I do infectious disease, so I take care of a lot of folks who have infections that have resulted from their injection drug use. So I take care of patients with HIV and hepatitis C, and people come in the hospital often with skin infections and heart valve infections. And so I prescribe Suboxone in the Brownstone building, and that's one of the most rewarding things that I've found out of all the things that I do. So part of my role has been to be a catalyst within the hospital walls. As Dr. Wolf mentioned, there's a lot of bias. There's a lot of training that's lacking on addiction. So a lot of generations of physicians have come through their training not really understanding much, thinking that this is a disease of willpower, and not understanding that there's a lot of hijacking of pathways in the brain that make people act the way they do. And especially in the ER, often the providers see patients at their worst. When they're in chaos, they're not feeling well, they're really having a hard time. Getting them into treatment is so key in helping providers understand that there's more we can do. So I'm trying to work with some of the providers ranging from the emergency room to some of the heart surgeons who may have very traditional views, and help them to understand the population a little bit better, and understand from my perspective, when I see people in recovery that are doing well, that are thriving, that are taking care of their families and working jobs, that are not coming in and out of the hospital often with some of these problems. I get them stabilized, I get to see them do well, but a lot of these other docs don't really understand the side of it. But people are really coming around, people are starting to have more compassion than they did in the past. And so slowly, gradually, we're having some culture change. I'm from the city originally. I grew up in the South End. I work in the city. I still live in, I live in the neighborhood. So I've seen firsthand, I've had encounters on my own where I've been driving down Park Street and saw somebody down and had a Narcan kit and was able to help intervene. So it's just really key that we try to equip as many people in the neighborhood and in the city with naloxone and make sure that they're understanding not to use alone and to make sure that their families are aware. And for me as a prescriber, the more that I can just give naloxone to anyone on the street, the more that people have it, the more good we can do. So I applaud everyone doing this work, and Mark in the community, and my part, I see it as within our hospital walls, knocking down a lot of that bias and stigma and trying to improve the access and trying to set up pathways within the hospital so that when patients come in withdrawal, we're meeting some of their basic needs. We're making sure that simple things we can do, like give them a sandwich if they haven't eaten, let them get some rest, give them adequate treatment for their pain, because a lot of providers have misconceptions that you're gonna make the addiction worse if you give something for pain, and that if you don't give something for pain, that you're helping the addiction, which is totally not true. So we're making some inroads there. And trying to get people on treatment, making sure that their withdrawal symptoms are treated when they're in the hospital. If they get methadone or Suboxone, instead of tapering them off, try to get them on and serve as that bridge to treatment long-term. Because we know that detox doesn't really work. When we send patients somewhere for 5 days, and I'm not knocking it, everyone has different paths of recovery, but looking at the studies and looking at the evidence, because that's what we tend to do in the medical field, is look at outcomes over time. So if we look at 1 year, the rate of people who have gone to detox come out at 1 year, about 90% of them have relapsed. So 10% success, that's poor. We can do better than that, and medication is not for everyone, but it has been proven to work better. So the more we can improve access and try to set people up with supports to succeed, if they do go into detox, coming out to their community, linking them with a lot of the community agencies that are very willing to take patients and work with them. Because we know that for a lot of patients, they may go somewhere for a few days, they come back to the same neighborhood, they have some of the same people, some of the same triggers, and it just doesn't go well. So we need to set people up for success in the hospital and then transition them back to their communities. So that's sort of where I come from. I don't know if there's anything else, Mark, you wanted me to go over. I'll leave it at that.
I do want to add just one more thing on that whole issue of length of treatment. One of the first questions that some of the patients will ask when I put them on, when we talk about Suboxone, is, when can I come off the Suboxone? And I say to them, maybe never. Maybe 6 months, maybe a year, maybe 5 years. And I tell them they need to look at this like high blood pressure treatment, diabetes treatment. It's no different. And you need to give the brain, just as what was said, time to change, and it's going to take a long time to change that. So there's no rush to get off Suboxone. And detox is one form of treatment, but as you said, it's not that successful. And Suboxone and medical assisted treatment with methadone and others are certainly another way to do it. So it's a longer term treatment, and that's something that also patients don't fully appreciate yet, and we have to get them to understand that this is a long process and takes time. Thanks.
So we really want to get to a part where we can have a community conversation, but I really quickly want to say we're grateful for Dr. Wolf, because from ground level, trying to change the face even of services and how they're given to our participants. When I approached Dr. Wolf early on about a project where we wanted to begin to give overdose care packages to individuals who come through the ED, because, and Peter's going to be speaking very briefly or very shortly, but oftentimes the agencies and the state have done a really good job of educating individuals about the dangers of overdose. But what happens is when individuals enter into or are engaged by first responders, whatever they have that's been given to them to keep them safe. You know, you have SSPs, ACT is here, President Latoya and Norman. They instruct their participants how to stay safe. We do it at Greater Hartford through CCAR. I see, you know, some people here from various agencies, Root, the whole nine. When the individuals engage, they leave. Once they leave the EDs, they don't have anything with them. So those people who are experiencing opioid use disorder and come out of the ED after a non-fatal overdose are oftentimes sick. So what we're trying to do now is develop a way to make sure they have the necessary tools to stay safe even upon release. Because we know that most of those non-fatal ODs are accidental. So speaking of ODs, as a segue, as a gentleman who not only is out here every day, who reverses these, but he also does a lot of writing about it. And I actually followed his blog before I got to meet him. So Peter Canning, AMR.
Thanks, Mark. Let's get this out of here. Hold on. Okay, my name is Peter Canning. I've been a paramedic here in Hartford for 25 years. When I started, I thought that people who overdosed had a character flaw, and that they got where they got through their own errors. There was no addiction training at all in our school. But over time, you know, where before I would just say, no, stop using drugs or you're gonna end up dead or in jail, over time I started talking to the patients and my view started to change. When I'd ask people how they got where they got, the stories that they would tell me were chilling. You know, they got hurt in an accident, they got prescribed drugs, they got stuck on them. They experimented innocently, and then they couldn't escape from the clutches of the drug. And the line that I heard over and over from these people was, I used to be a normal person. And when you hear that enough, it really begins to sink in. So I started to learn more things. This area here, I don't know if, I wish I had blown it up bigger, but this is a heat map of the overdoses that the AMR's done in Hartford. This is from the year 2017. Now we cover Park Street North. This area here is where we're standing today. This is from probably Hudson Street to Pope Park, and it's solid red. In this area, I have seen a lot of death. I have seen parents doing CPR on their children. I've seen a brother doing CPR on his older brother. I've seen Samaritans doing CPR on strangers. And it's not just the deaths. There's far more destruction that this epidemic has caused. There's diseases of the blood, HIV and hepatitis. Diseases of the heart, endocarditis. There's this terrible, terrible damage it does to people. And the diseases of the spirit, the despair that it is cast upon so many people. And over time now, I've been privileged to meet people like Mark and like many of the other people in this room that have taught us in EMS ways that we can treat our patients beyond just taking them to the hospital. Where before I used to say, just say no, today we have a little handout that we give to people. It tells them where they can get treatment, and if they're not ready for treatment, it tells them how to use safely. You know, we tell them don't shoot up alone, you know, do a tester shot. Make certain you have Narcan available. I mean, years ago, I never would have thought we'd be saying stuff like this. But it's about saving people's lives until they're ready for recovery. One of the projects I've been very privileged that AMR has been involved with is we piloted this in Hartford. After each overdose that we do, the EMT or paramedic calls the Connecticut Poison Control and they report on the overdose. Who gave the Narcan, how much was given, how old was the person, where did it occur, were they taken to the hospital? And we've been collecting this data, and it's been so successful that this project is going to be expanded region-wide and then statewide. And what it will enable us to do is identify spikes so we can get help out on the street. If a certain bag is linked to a number of overdoses, we send messages to the needle exchange vans and to Mark's Army, so they're able to say to people is like, either avoid this bag, or if you're going to use it, rather than using 5, use 1, have somebody with you and have the Narcan there. One of the best parts of the project, the data that came out to me, was before when I started, we were the only ones that had Narcan, the paramedics. And we would get there, and many times we'd get there too late. But now, through the first responders and community Narcan, half the time before the ambulance arrives, Narcan has been administered. And 20% of the time, it's being administered by lay people. Where before we would arrive to find somebody doing CPR and we weren't able to bring them back, now we're having cases where we're showing up and the Narcan has been given, and the person who they were doing rescue breathing and in some cases CPR to is now sitting up talking. It's really a wonderful thing to have seen. So sort of, I guess, in conclusion from this job, I've learned that we're all gonna die, you know, but how we're valued and how we're judged is in how we live, and do we look out for our fellow man. And I've been really, you know, wondrously pleased with all the people that I have met through this, through these meetings that we've had and the work that's being done in the street. And you know, in the end, we are our brother's keeper, and that's how we're going to be judged, and that's how we can hold our heads high. You know, all at AMR now, we're a part of Mark's Army. We've been deputized, and we're out there trying to do the best that we can. So, thank you very much.
Okay, so what I'd like to do, if you will, if we have any questions from the audience, I'd like to, at this time, be able to, you know, through the help of others also, is address any questions or concerns before we go into the training, the overdose prevention education. Any questions? Hi, Pat.
More specifically to the doctors, I understand they're trying to change the rule about people that have gone into an ER as far as somebody coming in, getting Narcan and walking out without getting additional help. Is that okay, more for the doctors, I guess. I've seen newspaper articles and a couple of posts on Facebook. There's a mom in the state trying to get the law changed so that when somebody gets treatment, they're not allowed to just leave because I guess her son went out, used, and died. So I wanted your opinion on that and what your hospital's doing, and if you plan on changing the routine at all.
Well, there is a problem with the U.S. Constitution, so patients do have their own rights. There are patients who will make the wrong decision despite our best efforts. A patient can't leave can't leave if they're not mentally competent. But once they've been revived and they're mentally and physically stable, one gets into a bind in terms of at what point are they making the wrong decision versus they're not competent. If they're competent and they're judged to be competent, to prevent somebody from leaving and forcing treatment is very questionable. It's one thing when you have a schizophrenic who becomes a danger to themselves or others, then you can legally put them in the hospital and treat them. Someone who now has returned to baseline, just like a diabetic, gets low blood sugar, Peter comes and rescues them, gives them glucose, and they are now normal. They don't want to come to the ER, they don't want to come to the hospital. Peter will try to do his best to convince them to get checked out, but if they don't want to go, Peter doesn't have the right to duct tape and tie them up and bring them to the hospital. So I can understand where this is coming from to force people into treatment, but you are starting to tread on people's constitutional rights. So it's a difficult question.
Except I'm going to say that when you and I were raised, because there's a lot younger people in here, there used to be hospitals available for mental illness issues. The hospitals are pretty much gone. St. Francis has been wonderful. I brought patients up there. I come from Bristol, but an awful lot of hospitals will put a Band-Aid on. And I keep hearing the words imminent danger as opposed to a danger to themselves or others. But all of a sudden I'm hearing if it's not an imminent danger, they can't do anything, which makes no sense. You don't have to wait until somebody has the noose around their neck to help them. And that's one of my big issues with harm reduction right now. I just don't think we're doing enough treatment-wise. It's hard to get people into treatment.
I just wanted to add another thing. I hear your frustration completely. It's hard on our end of it also to see patients who have come in the hospital. They may have stayed for a few days. They're feeling a little bit better because they might have gotten some antibiotics and some fluids and a little bit of rest. And then they want to leave. They're ready to go back out there again. And like Dr. Wolf said, they have capacity. The vast majority of these patients, they have decision-making capacity. We may not agree with their decisions. Sometimes the doctors will call the psychiatrist in to come and assess them, which is kind of bogus because we don't really need a psychiatrist to tell us if a patient is able to understand and accepts the risks. But there are situations, unfortunately, where patients have heart valve infections and they're very, very sick. They may leave from the intensive care unit, and unfortunately, we cannot, against their will, confine them or deem them incompetent. So it is very hard for us to watch. We don't like to see people go any more than family members like for them to come home untreated.
Hi, my name is Rhonda Leonard. We're here for the Hartford Community Emergency Response Team. Send a shout out to our CERT team. My question, Mark, I asked you earlier, what's the difference between opioids and meth? Can you explain that?
Yes, well, opioids are the overarching term for a class of drugs. So you have opiates and you have opioids. Opiates are the drugs that come from the poppy plant, heroin, codeine, no, Percocet is a semi-synthetic, that's an opioid. Now, and there are others so your opioids are your pharmaceuticals, they're your prescription pain medication. Now, when you talk about meth, you have to say it out because meth could be taken a couple different ways. You have methamphetamines, which are stimulants, and you have methadone, which is an opiate. It's actually the longest lasting opioid. Methadone is an opioid, I apologize. Methadone is used as a medication-assisted treatment because it's long-lasting. So it's sort of a replacement therapy. Am I using the right terminology, Dr. Wolf? I mean, Dr. Deutsch. And Suboxone is the other that you'll hear as a part of MAT. MAT, M-A-T, if you don't know, medication-assisted treatment. These are some of the more preferable methods to treat opioid use disorders right now, so that's where all of the focus seems to be going. Conversation, did I answer that, I hope? All right. This conversation today is really because there, you know, from where we are, we see a lot of frustration from individuals. You know, I had a conversation with a young lady at the Boost store here in the next block, and I asked her, you know, I asked her first off, how long has she been working there? And she had said since June. And I asked her in that amount of time, how many overdoses had she witnessed? Now, generally when I ask somebody a question, they'll pause, you know, you'll see their eyes look up as they try and recollect, but she just like really quick shot the number 9. She shot the number 9 right out of her mouth, and then she started pointing to parts on the block here where they have taken place. Now, coming from where I'm at, I've got some issues with that. Number one, you know, there's not much we can do about this epidemic right now, but there are some things that we can do to help on the backside, because overdose is a preventable outcome. Fatal overdoses can be prevented. So we've had naloxone at the layperson level here in the state since 2014. At that time, when we first began to address it from a layperson level, we used an intramuscular dosage, which nationally remains the most or the best practice. It is also the most sustainable. We also know that people who use intravenous drugs are not scared of syringes. So if we can get to this model again, because right now in the United States, I want to get back to the conversation, we have various methods of administering naloxone. You'll see some on the table over here. You'll also see about 1,000 doses of intramuscular medication on that back table back there, all of which costs less than one of these. You know, we can probably pass out 10 kits for the cost of one of these. I'll go further into that. What we need to do in our area and what we're really trying to work toward is to begin to also get individuals, people at home, to get stores, restaurants, the different establishments to also take a part in this, that we can get you some trainings, host some other trainings here in the area, and begin to get this medication into their hands so that they can also assist first responders. I'm sure Peter will tell you now, as well as, you know, HPD, fire, that when they respond, a lot of times someone has already administered naloxone. You know, so if we can keep this up, we know that, you know, DPH made a statement that, you know, we're making headway, that some of the numbers have begun to level off. You know, I have my own personal feeling about that, but we can say, I'd love to be able to say, and I'm sure Norman and LaToya would say this also, we'd love to believe that as a result of us getting medication into the hands of the people who need it most, that we're beginning to see a change, that things are not as steep as they were, that we're not seeing a 15-20% increase in death each year as we have. But what we do know is that here in this section of town, here at Park Street in Frog Hollow, this is the first training of this sort. Yet this is the hardest hit area of the state. How is that possible? How is that possible? Yes, ma'am.
So for me, I'm still in school, And I recently learned that Portugal's legalized their drug use, and their crime rate and their overdose usage has actually lowered. And the only reason why I'm saying this is because if we actually do have a problem with crime, with the drug uses inside of our state, why don't we actually legalize it? What's the difference between telling somebody, if you're gonna do it safely, and then legalizing it? Like, they're still gonna do it. I mean, they're still gonna have more, that way we can have way more resources if that's the case. Because if you legalize it, then you're gonna have a whole store full of what you can do, what they're gonna sell you your product, and then they're gonna give you an extra packet like, hey, if you overdose, this is what you need. You feel me? And a lot of people don't realize that legalizing something could actually lower crime rates 10 times more. And I'm in school and I know that. So when I talk to adults, they look at me like, how do you know this? I'm like, because I go to a really good school. So that's actually my question. Instead of saying, yeah, you could do it. If you're gonna do it safely, why not just legalize it?
You want a part-time job?
Why not just legalize it?
Yeah, that's about the best answer I can give you. As my mom used to have a real simple response to a question like that. My mom would say, because that'd be too much like doing right. That being said, politically, we live in a society where that's just probably right now, we're making headway. I mean, the fact that we have naloxone, that Dr. Wolf and his team were willing to give out Narcan from within the hospital, that's huge. From not even wanting it on the property, a couple years ago. The same Dr. Deutsch will talk about that we can now go in to the hospitals and have conversations and training with med staff, that we can do it with, HPD. We're making headway, but it's very slow. It's very tedious. We live in a puritanistic society. And I'll say Connecticut even more so. But we're making inroads. I know people get tired of seeing me coming. Ramona's here. There are a few others from DPH. When they see me coming, they know that's part of my thing. What are we going to do? What are we going to do? How come we're not doing it? What are we going to do? Can we do this? Most of the time, I'd rather apologize than ask permission. But can't always do that. Yes, sir.
As far as the emergency rooms are concerned, have they at either Hartford Hospital, St. Francis Hospital considered, or do they currently have in place a recovery support model, whereas a person who comes in and overdoses and is basically survived that, where a person who is basically a recovery coach, someone who is currently in recovery and has that type of training to actually encourage them and inspire them to step into an area of getting treatment rather than just treating them for the overdose and providing nothing more than medication.
So CCAR, Connecticut Center for Addiction and Recovery, you want to answer that question for him?
Yeah, I'm a recovery coach from CCAR, and we go into like 12 hospitals in the state, and we connect with people after overdoses and try to see what we can do to support them in their recovery, whatever recovery they're trying to do. So, and basically that's what we do. We usually get dispatched here if they want to see a coach.
So this is one of the areas where recovery coaches have been enlisted in the ED. Recovery coaches have also been enlisted at, the various MAT institutions. The Root Center has recovery coach. HC is a HCRC now, which is over on fish. We call it fish fry. We've called it fish fry for 30 years. Has recovery coaches. Various other entities also have recovery support specialists. That's recovery support specialists. Marcia, recovery court specialists, Advocacy Unlimited. That's their model. Greater Hartford Harm Reduction, we have ambassadors. There are navigators. There are different other types of outreach mechanisms in place that are in part are peer-led or generally people who have lived experience that help provide services back to the population. Are there any other questions? And Michelle.
Hi, George Acosta from Temple Fay. Is there a difference between drugs, like you're saying, Naloxone, Narcan, and whatever other drugs they do to reverse the overdose? Yeah, or what is the difference? Like you mentioned a couple of names. So.
Okay, so the question is the Narcans, the different types of Naloxone, which is the generic name for naloxone hydrochloride, has been around for many, many years. It has traditionally been used as an intramuscular formulation. They used to come in 10 cc doses. These are 1 cc doses, and they're administered by way of an intramuscular syringe. There is also, when we first had a layperson or first responder distribution, there was the Amphistar 3-piece. It required some assembly, but Narcan or naloxone is an antagonist. It is a blocker. The body is made up of receptors, and opioids bind to these receptors. So when you introduce naloxone, it is a blocker. First off, the sole purpose of naloxone is to knock whatever opioid that is on these receptors off, and it forms a block. So essentially, when somebody overdoses, they stop breathing. Oh, Michelle, you had a question? Yeah, I'm going to come back to it. I'm going to go on the start.
My question is just related to the point that you had made about the conversation with the employee at the booth store and how you want to be able to reach the people that are being immediately affected out, on the street. So is it a legal reason that's preventing us or the community organizers from going out and doing just grassroots efforts where you're going out on the street and giving people the Narcan? Or is it just a resource issue where we don't have enough people to go out and do that? Because trainings are great, and when you have community forums and large trainings like this, but you don't reach a lot of people that are immediately affected. Either they're not gonna come or they're not aware. So is it a legal reason that we can't just go out and give people the Narcan doses, or is it more of a resource issue?
And Ramon, correct me if I'm wrong with this. It's a resource. Right now, it's a resource issue. All it takes is a very brief training, which we're going to do here today. Now, don't get me wrong. I do trainings all over the state, outside the country, outside the state. They last anywhere from an hour to 8 hours. It really depends on how much information that we disseminate. A street interaction with someone who has lived experience can take place in about 3 minutes. 3 things you need to know, and I'm going to go through those things. But to get back to what you were saying, resources. and I'm going to take that as my plug, as my cue, is the Greater Hartford Harm Reduction Coalition has devised a tool that is not only being used here, but being used around the country as well. It's called a Rover. It is a portable public health response to the opioid epidemic. Very easily it rolls. It's able to deploy in a matter of moments, and within it, it has everything that is necessary for harm reduction best practices. When we talk about harm reduction has been around for some, what time is it, Logan? 7:10? Harm reduction has been around for well over 20 years now. Harm reduction is a set of principles and strategies aimed at reducing the negative effects of illicit drugs. So when I introduce myself, I say, I'm Mark Jenkins. I'm a harm reductionist. It is my job, it is my calling, it's my ministry, despite my language, to help individuals reduce the amount of harm they cause themselves and their communities as a result of illicit drug use. Now, what we do or what I do individually really depends on the individual I'm talking to, because everything that we do is really adapted to the individual. It's about listening and then just providing and helping individuals reduce barriers to staying safe. Everything that we're talking about today and the reason that we're here to have this conversation is all about trying to help individuals stay alive, because we know from history, does just say no work? Does just say no work? Harm reduction acknowledges that people are going to use illicit substances. Harm reduction acknowledges that people are going to have certain behaviors. It is our duty to help people stay safe in whatever those behaviors are, until at some point another message or intervention can come along. But more often, in some cases, some people are okay with their use. They just need to stay safe in it. So whether a person makes a decision to enter into treatment, if a person hears a word of encouragement from the Lord, we never know how or where it's going to happen. What we do know is that dead people don't make better decisions. Dead is final. Harm reduction, if you've never heard of the term harm reduction, and most people, when you say harm reduction, how many people have heard the term harm reduction? Can I see it? Okay, so what does harm reduction mean to you? Different people will have different answers, but one of the cliches around harm reduction is meeting people where they are. And I'll agree with that, but I have to go a step further. It is meeting people where they are, but it's not leaving them there. I can't ask you to stop doing something if I don't give you something in place of it. So, if you've never heard of harm reduction, you've most assuredly practiced it. I would like to recognize, yes ma'am, question?
So, Will DeLeese from Mutis from Hartford City Council. But the question is, at the state level and also at the city level, in terms of policy, how can we be more helpful? How can there be more assistance? What is it that you need?
What is it? Wow, that's a loaded question. That's a loaded question. Say, who said it? Say it again. We have, I don't even want to say a small army. I've got the medication. I've got more medication on our shelves than any community-based organization in this state. I can say that confidently. We have the capacity to get into this community. Without doubt, we have the gatekeepers, we have the staff, we have the desire and the passion to get the work done. What it is that we miss drastically, or most importantly, is the finances to carry out that mission. I can't ask individuals, we have volunteers. We get, money from the state level. This wasn't about really putting Hartford on blast. Liani Arroyo is the director of Hartford Health and Human Services. She's been wonderful. But there hasn't been the money there in place to support these efforts. So now, as an executive director, as an administrator, I'm reaching out to the council to say, we're here. Everybody from around the state has reached out to our organization, and we've provided responses and solutions. But we need some help here. So if to answer that question just wholeheartedly, we need some financial support so that we give more bang for the buck. If you need me to spend that right there, I've got $500,000 worth of medication sitting on the shelf. The state doesn't have to buy that. The city doesn't have to buy that. I can make money go a lot further. So you all hear me here begging, like the old TLC song, I'm not too proud to beg. All right? I have no problem begging. We need the support. We will produce the outcome. Very visible. So, did that answer your question? Thank you, dear. Any other questions? Yes, sir.
I live in the Pete Ramos. I'm a member in the neighborhood. I live in the neighborhood. I took the Narcan training with you a couple of years ago. It was due to work-related reasons. We were seeing that the teenagers that we work with were selling opioids in the area, and other teenagers were buying it, so it was better to get us trained just in case. However, between the time, I live in this neighborhood. After I took your training, I had to use the Narcan that you used me in this neighborhood twice. I think that for us to fight problems like this, we need to, as a community, take this training and be ready to use it. My neighbors know that I have it. I've been asked to go and help out, like I said already, twice since the training. That's one way of handling it. Another thing that we can do as a community, as neighbors, we know where and who is doing this and selling this. 757-4000 dispatch. We have to give the information to our community-based officers. We know the areas. If we want to take control of our neighborhood and we want to help out our neighborhood really as a community, we have to prevent it, and we also have to get ready for things when things happen.
Okay. Any other questions? So I'm going to say that even if you've never heard, and thank you. If you need more naloxone, make sure that you come see us, because I tell anyone after they receive our training and you use naloxone, come back and see us and get more. All right? Just give us some brief information. Was the person revived? Did you call 911? Really brief, couple of questions, that's it. But as I said, if you've never practiced harm reduction, you've never heard of it, you have practiced it. Anytime you ever put on a seatbelt, seatbelts are designed to reduce the amount of harm that would take place in the event of an accident. But every time you put on a seatbelt, have you wanted to drive into another car? I don't think so. The same with fire extinguishers. Fire extinguishers are a form of harm reduction. In the case of a fire, use a fire extinguisher to reduce the dangers or the harm from the fire. But every time you see a fire extinguisher, does it make you want to start a fire? I don't think so. And on the flip side, if you ever go on a boat and that boat began to sink, what are you going to ask for? A what? She said another coat. Let's go in here. A life preserver. If the boat was going to sink, you're going to ask for a life preserver. And what if that person said no? You knew the boat could sink when you got on it. You'd look at them like they'd lost their cotton-picking mind. Well, this is what happens, and this is really what happens when we don't make sure that this medication is available to everyone. This is what happens when we think that by providing this medication to individuals, it makes them or sets them up to use more. It's just not the case. It's not the case. Now, there are other things that we use in harm reduction right now, especially because of the amount of fentanyl that has permeated the drug supply in Connecticut. And we did a study last summer that talked about fentanyl, and you can come over and see this. Fentanyl is an opioid also. However, it's 50 to 100 times more potent than heroin, and the cost of it is a heck of a lot less. Now, we do this training every Thursday, ladies and gentlemen. We have for the past 3 years. I'm going to do a very abbreviated piece today, but I welcome you. There are flyers to come out on Thursday. Get the whole piece. I'm sure Know Thy Neighbor from here, from this point, we're going to get together and do some more in-depth trainings and really try and target some conversations. It's really good to see you all out here tonight, because I tell you, for all of the forums that we do, is usually the usual suspects that show up, which are other providers. So to see you all here, to see the peace builders here, to see the CERT team here, to see the support from fire and PD, this is encouraging. From where I stand, this is encouraging to see that we have this conversation taking place. Fentanyl test strips are something that we use also to educate our consumers, our participants, to make them aware of the dangers of the drug supply and to make sure they have a knowledge base from which we empower them to make better decisions. If they know what they're going to consume, they can tailor the use. As Peter said, getting the message to them not to use alone, to make sure that they have Narcan available, naloxone available. Now, I've asked the staff to pass out this little handout. And there's another one over on the table. Andrea, hold up the little dope fiend booklet right there in front. It will never win an award for politically correct title, but I guarantee you it's the most complete FAQ. It will answer any questions that you have around overdose. Likewise, our business cards are there. I don't know if LaToya and Norman brought cards there with ACT. They also do the work of syringe exchange here in Hartford. But 3 things that you need to know if you have this, 3 things you need to know about reversing an overdose. Recognize, respond, and evaluate. Recognize, what does an overdose look like? Has anyone in here ever witnessed an overdose? Tell me, what'd you see? Huh? Eyes? Anything else? Huh? Sweaty? Shit, that's me right now. Oops, I didn't swear, did I? Sorry. All right. Change of color. Okay. Blue lips, blue fingertips. Anything else? Foaming at the mouth. You know what? Sometimes people lock up. They'll look at you, the lights are on, but nobody's home. They say sometimes people will snore. Let me sit down for about 5 minutes. It'll be evident. Don't hit me with Narcan, though. However, what I do want to say is, what happens if someone meets those that looks like they may fall into that category? So again, there are certain things that always take place. Respiratory depression. That's what happens when somebody overdoses. Basically what happens is that the body is made up of all these receptors. The brain has all these receptors. And when you ingest too much of an opioid, the opioid binds to these receptors. And when these receptors become overloaded, they tell the brain to shut down the central nervous system, i.e. you stop breathing. It doesn't happen right away. Only in about 12% of the incidences does it happen like what you see with somebody in the movies with a spike in their arm. Now, some of the fentanyls are a lot more fast acting when that does happen, but more often that happens because somebody likes to boot. Again, that's another conversation, another place. But if you believe someone to meet that criteria, and again, it's in that pamphlet that talks about it. Once you recognize it, what do you do then? You respond. Now, the response, as we talked about, has changed over the years. It's changed with the information. But we always say from now what you do, if you believe someone's ODing, call 911. We'll say, what? Call 911. I go to prisons, wherever I go, in a room full of inmates, I'll say, call 911. We have things in place called the Good Samaritan law. So again, if you look at that pamphlet, on the inside of that pamphlet, it will tell you we have some people call it the 911 law. The Good Samaritan law states that if you're acting in good faith and believe someone is overdosing and you call 911, you're not going to be prosecuted. The number one reason that people don't call police or 911 is fear of prosecution. Number two, fear of litigation. We live in a litigious society. These laws and statutes said you're protected from that, okay? So, the response, if you believe someone is overdosing, stimulate a response, a fist, right across the sternum. My favorite is right below the nose, across the gum line. If you lay into somebody's gum line with your fist, and they'll probably speak in a different language. It's painful. It's about stimulating a response. They respond, okay, no harm, no foul. If they are not breathing, we do rescue breathing. We don't do CPR because I'm not going to teach you CPR in the next 2 minutes. However, if you get a kit from us, all the kits have a couple of things in common. One of those things will always be a CPR face mask, in case you don't know the individual, but we talk about rescue breathing, even though it's a CPR face mask, we talk about rescue breathing. Lie someone flat on their back, lean their head back, pinch their nose, breathe into your mouth till you see their chest rise and fall. You do that once every 3 times for 3 repetitions, once every 5 seconds for 3 repetitions, and you take some breath for yourself. Now, somewhere along here, if you have naloxone, use it. If you have naloxone, use it. A lot of places now will say if you believe somebody to be ODing and you got Narcan, use it first. Now, okay, there are 4 different types of administrations in the US right now. The most tried and true, the best practice is an intramuscular dose. Intramuscular because it's an intramuscular syringe. They come with pre-measured doses. If this were an emergency, all you would do is pop off the top of that dose. I tell people, take some air, put some air into the syringe. Just insert that syringe into the naloxone, push the air, let go. It'll automatically begin to pull that medication out of the vial on its own. Very simple. Once it's pulled the medication out of the vial, take the excess air out of it. Again, it's going into a muscle, hence the term intramuscular. This goes into the thigh, into the bum, or into the arm, in a muscle. Now, here is the wonderful thing about naloxone. This 1 cc, 0.4 milligram dose of naloxone will reverse the effect of any man or woman that has ingested any type of opioid, fentanyl, carfentanil, acetylfentanyl, remifentanil, oxyfentanyl. It does not matter what that fentanyl is. Fentanyl is an opioid. Naloxone is an opioid antagonist. It's an opioid blocker. Here's the better part about it. She said, Okay. She said, what? Yeah. I'm not going to tell you what it tastes like, but it's not something I suggest you do for yayas. The reason I do it is to prove a point. Who knows what that point is? And no, I'm not an idiot. What's the point? No harm, no foul. The sole purpose for naloxone is to reverse the effects of an opioid overdose. If there are no opioids on board, no harm, no foul. I could drink a cup of this stuff. It wouldn't produce a burp. It doesn't taste the best, but you know, so when in doubt, use it. What's the worst? You know, you jab somebody in the backside, you probably get pissed off anyway, you know. But so that is the intramuscular dose. The other is what you're going to receive tonight if you leave out of here with some. It is the Narcan. The nasal Narcan is an intranasal dose under the brand name Narcan. Narcan is to naloxone like Tylenol is to acetaminophen. It's a brand name, okay? It simply comes out of the blister pack in one piece as such. You would put that in between your 2 fingers. You insert it into the individual's nose. There is a plunger there, right into the individual's nose, and then you push it once, just one real quick push. Okay? That's it. That's what it would take to save a life. A person who may seemingly be unresponsive, not breathing, you give them a dose of naloxone, generally within about 2 minutes, they'll take a deep breath and come to. If they don't come to, then there's always 2 doses. That's the nasal Narcan. We also have Evzio, which is an auto injector. We have these as well. They do the same thing. It's an automated intramuscular device that does this. When you pull it out of the container.
If you are ready to use, pull off red safety guards. To inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds. 5, 4, 3, 2, 1. Injection complete. Seek emergency medical.
See, is that there's a needle that's pinned that to that table. Okay, now this comes with a trainer in the box, and it allows you to do the same thing that I just did without medication. But I can't tell you on how many occasions that I've told people, make sure it says trainer when you do that. Now watch this. Now it's retracting, but I've heard on many occasions, boof, somebody go, oh! And I already knew, like, I find it funny as hell. I'm sorry, I have a sick sense of humor, you know, but that's all that takes to save a life. Now, the difference between the other methods and this one right here is the Amphastar 3-piece. It requires some assembly, and if you were to use it, it's half in one nostril, half in the other nostril. But this is an intramuscular dose that's been fitted with a mucosal atomization device or MAD device that turns it into an intranasal product. But it's the same thing, out of the box. Okay? All of this is to help preserve life. The sole purpose of this is to help preserve life. Once you administer that dose, the individual will respond. If they don't respond in 2 minutes, give them a second dose. You've already called 911, they're going to respond. When you call 911, give them a clear location of where you are. Tell them you have someone who is not breathing and unresponsive. They may ask you, is it an overdose? There was a time we would say, just let them know that they're not breathing and unresponsive. Things have changed over time, you know. Just give a clear, concise indication of where the individual is. Stay with them. When they come to, they're not going to be combative. I've heard people say, oh, they're going to come to wanting to fight. In all my years of doing this, I've never had anyone raise their fists at me after I performed a reversal. Okay? They may come to disoriented. They may dispute the fact that they've even overdosed. Just let them know. This is just in a loving, caring way. You know, you were gone. This saved your life. You know? Make sure you stay with them. Whatever opioids have various half-lives. The half-life of naloxone is between 30 and 90 minutes. So generally after about an hour, that block, that it's the sole purpose of naloxone is to knock whatever opioid that's on those receptors, it knocks it off and it forms a barrier which allows the person to breathe. However, the naloxone has less of a half-life than whatever opioid that has been consumed. So when that naloxone wears off, whatever opioid that was in the body can rebound and has the potential to send a person back into overdose. So when a person comes to and they're a little uncomfortable, let them know. As the naloxone wears off, you won't be quite as sick. However, if you use while you have the naloxone in your body, there is a very high chance that you can overdose. Okay? So again, that's the evaluate piece after someone comes back. Recognize, respond, evaluate. Medication here is free. Thursday nights, we do the training at 1229 Albany Avenue. We have any questions so far? Yes, sir. I have never heard of one. Peter, have you ever heard of one? Dr. Wolf, have you ever heard of one? And my 20 some odd years of doing this, and we did this underground. We first got naloxone underground here in this state in 1997. Yeah, underground. A lot of the stuff, is Ramon still here? A lot of the stuff we did early on was underground. Any other question? Eli, you have any remarks?
I had a question.
Oh, question. Where to go?
Is the nasal administration affected? Is it still effective if they've already stopped breathing?
Well, good question. Many people have said, what if sinuses are clogged, people are congested, what if they're not breathing? As long as the heart hasn't stopped and their breathing is still shallow, this works by penetrating the mucous membrane to get into the bloodstream. The only other difference between them are the varied strengths. The intramuscular is a 0.4 milligram strength. The Amphastar is a 2 milligram dose. The nasal Narcan is a 4 milligram dose. So it's actually 10 times as strong as this, but it's a very small dose. And Peter, have you seen any side effects?
That's 4 milligrams, but the bioavailability of it is only at 50%. So it's the equivalent of it's the equivalent of 2 milligrams given into the muscle. With the 4 milligrams, we have seen a lot more vomiting or agitation, but it's a lot better than them not breathing. And it's much simpler to use than some of the other ones.
Right now, as far as the strongest, the Evzio auto-injector at 2 milligram, the new 2 milligram dose, offers the highest concentration of medication into the bloodstream. But at a price tag of $5,000, it's sometimes out of reach. Any other questions? I should say they are very gracious to give us a lot of this medication free. We've given out over $4 million worth of this product here in the city. Any other questions? Well, I'm going to bring Eli back out, and please, there's a lot, that we, as a matter of fact, the Greater Hartford Harm Reduction Coalition, we've opened up a drop-in resource center at 557 Albany Avenue. It's open 7 days a week. It's different things to different people. Please don't hesitate. I have business cards over there. Marsha's gonna have medication. She's back there in the back with the red scarf. Marsha DeForest, she's from the North Central Mental Health Regional Board. All right, and we thank her for coming out to dispense naloxone. And Eli.
Guys, give it up for Mark. So Mark, I want to thank you for being here and for really the partnership in order to bring this discussion forward. For me, this also hits home as well, and I'll be very quick. Sometime last year, I was at a store, and there were two individuals that overdosed in front of me, and I was like, man, these people are gonna die. So not having the training, not having the access to this, I called 911 and awaited for individuals to come and help them out. But now, in that situation, I'll be able to help moving forward. So this is a great thing. And look forward to hear more about this here in this neighborhood. Our Know Thy Neighbor team will be focusing. This is one of our priorities that we'll be working on. And there are different things. And one of the questions that came out was on the policy side. So we're gonna effectively be working and partnering with our municipal leaders and also the state delegation as well, and seeing what could be done differently than what we have today. And here, you guys are going to see one of these flyers as well, Know Thy Neighbor information, and we have a meeting coming up March 11th at 6 p.m. and we'll be posting on our social media pages as well that information. So thank you guys for being here, and I'm sure we'll talk soon. Thank you.
My name is J. Stan McCauley, and I do business as Lightsource Productions. I provide professional services in the area of strategic video communications. First, what we do is we help you craft your message using what I call the rule of the 5 W's: who, what, when, where, and why. We do event documentation, content acquisition, full-scale productions, editing, and of course distribution through our social media television network. And with social media, video is more important now than it has ever been. Whether you're talking big business, small business, nonprofit, church, or just an individual. Let's say you plan you're planning an event, a wedding, whatever the case may be. But let's say a big event, but no video. And you spent all this time, all these hours to put this event on, and maybe 100, 200 people attend the event. But more important than that is that thousands could attend by watching it on social media. But of course, you don't think about this until after the event is over. You can't afford not to capture it for social media. And despite what people think, I am affordable. Give me a call. Let's plan your next video project and share it with the world on my social media television network. I promise you that you will have the attention of one person, me.